All right, so what I wanted to do is go over a few treatment trials in schizophrenia that I actually was intimately involved in, and that I think may be interesting to shed some light on how we should treat schizophrenia. These are my conflict of interest. I've done consulting for these 3 drug companies, and I'm still working with Alchemies and Otsuka. So what I want to present to you is a few of these trials, not all of them. A few are ongoing, but essentially the first 3, UFEST, Optimize, and ULAST, which, as you can see, are large trials done in schizophrenia. And the 2 below, Psyscan and Purpose, are still ongoing, so I have no results to present there. Psyscan is a study looking at predictors of response in ultra-high risk. You can see through about 350 and 500 first episode patients. And Purpose is a study using omega fatty acids to prevent conversion into full psychosis in subjects at ultra-high risk. Again, those 2 are ongoing. I'm not going to present results on those. The 3 on top I will be presenting. You can see that the first one is published, and I won't spend too much time on that. The Optimized study is in fact also published, but I'll be a little bit more extensive. And then I'll be most detailed on ULAST, which is a study that was just completed, and we just submitted the paper, so that is the most recent one. So the first study is the UFEST study, the first treatment of first episode schizophrenia, and UFEST stands for the European First Episode Schizophrenia Trial. Now, these studies usually get a lot of publications, which is, of course, a nice side effect of these. This is a non-exhaustive list. There are many, many more, but I stopped here at 2016. The main study I'm going to present is the one that's underlined, that was published in The Lancet in 2008, and the one that was published in the American Journal in 2009. Again, there are many, many more papers if you want to look them up. You just have to go to PubMed and you look at UFEST, and you'll find them. So this is the publication, the main publication with the main results of the study. And I'll have to give you a little bit of background why we did this study, because when this study was conceived, which was obviously quite a few years prior to 2008, so let's say the early 2000s, there was this issue of, well, we have the 2nd generation antipsychotics, for instance, risperidone, olanzapine, you name them, quetiapine, ziprasidone, you'll see them in a minute. And they were touted to be superior to haloperidol and the typical, or otherwise called, 1st generation antipsychotics. But it was said, yes, these comparisons were not really fairly done because the comparison doses of haloperidol were far too high, which was true. I mean, they were around in the range of 10 to 12 milligrams. And we by then knew that if you look at PET scan studies, we knew that dopamine occupancy was almost complete, almost 100%, with doses of haloperidol that were about 4 milligrams total daily dose. So the issue was, said, okay, well, are these 2nd generation antipsychotics really superior to low doses of haloperidol? Because that would be a fair comparison. So that was one of the reasons why we did this study. And the other reason we did this study is that the studies comparing 1st generation and 2nd generation antipsychotics, or 2nd generation antipsychotics with each other, were usually in highly selected samples, mostly in chronically ill patients instead of in 1st episode patients. The duration of trials was usually quite short, only a few weeks, 4 to 8 weeks maximum. And we all know that schizophrenia is a chronic disease. So what does it tell you when a drug is effective for 8 weeks or 4 weeks? the doses that were used of the first generation were too high. I just mentioned that. The outcome measures was really reduction in symptoms. And is that really what we're interested in? Is it reduction in symptoms, or is it a much broader measure that I'm going to mention in a minute? And then usually there were a very large number of dropouts in these studies. It was not uncommon to have these short trials, 4 to 8 weeks, have dropout rates of about 40 to 50%. So what is the generalizability of these data? So what UFEST did was to have a representative sample. We took all comers, including patients with drug abuse and suicidal ideation. We used, as I said, a low dose of haloperidol as a comparator, 4 milligrams. We had a long-term follow-up at 1 year, and we have a real-life outcome measure, meaning retainment in the study, or the converse, which is the same thing, all-cause discontinuation, and rehospitalization, essentially having the hypothesis that patients will vote with their feet. If they don't like the drug, for whatever reason, we'll get to that in a second, they'll just stop taking it. And if they stop taking it, they'll probably relapse and have a rehospitalization. So that is the background of the study. It was a natural pragmatic design, meaning we have about 5 arms, as you can see. I mean, to do that double blind is almost impossible. But also, we wanted to reflect real life. And in real life, the patient knows the drug he or she is taking, and the doctor knows what he or she is prescribing. So it was an open but a randomized study, a non-selected sample, like I said. And we said we want to have first episode patients, of whom mostly will be medication naive. And the outcomes are already mentioned. So this was a study. We assessed about 1,050 patients for eligibility. We have about 500 randomized, and these are the 5 arms. Haloperidol, as I said, low dose, up to maximum 4 milligrams. Amisulpride, a highly effective antipsychotic that actually is not available in this country, unfortunately, as you'll see in a minute. Then we have olanzapine, quetiapine, and ziprasidone. Now, it's often asked, why wasn't risperidone in there? Because at that exact same time, there was a study ongoing comparing risperidone to a low dose of haloperidol. So we thought, we're not going to redo that study. And that was a study by Nina Schooler, I think, done at that point. Okay. So I'm not going to go in all these details, the number who discontinued and who dropped out, because I'm going to show you that in a graph. But you could see it was pretty well balanced. The only arm that was slightly lower was ziprasidone, and that was the reason that it was a little bit later introduced, and in some of the countries it was not available at the start of the study. So that's a little bit smaller arm. Now, these are the main results. And you can see there are 4 panels. I'd like you to focus on panel A, which is the Kaplan-Meier survival curve, as you all know. And this is, how many patients stay on the drug that they were randomized to. You can see in red is haloperidol. You can see that all the way to the right. You can see gray is quetiapine. Light blue is ziprasidone. Green is amisulpride, and blue, therefore, must be olanzapine. Now, you can see, again, panel A, that the all-cause discontinuation, so discontinuing all drugs, is really quite different between the drugs. And in fact, what we found is a highly significant difference comparing the second-generation drugs with that of haloperidol. You can see that after a year, only 30%, or slightly less than that, is still taking haloperidol, whereas about 70, a little bit over 70%, is still taking olanzapine and amisulpride, meaning that there was quite a big difference. And interestingly, in many of the meta-analyses, in fact, olanzapine and amisulpride come out as the most effective antipsychotics around. So this, in fact, corroborates that. Panel B is, I find, the most interesting one, because that shows what is the reason patients drop out. And you can see the top two lines are, again, amisulpride and olanzapine, and very, very few patients actually drop out because of lack of efficacy. But on haloperidol, on the 4 milligrams, and ziprasidone and quetiapine, many more patients drop out of efficacy. And then look at the side effects. Panel number C. Very few patients actually dropped out or discontinued, I should say, taking the medication because of side effects. And that will be my main take-home message for you in this particular study. Because you probably well know that many drug companies have tried to sell you drugs and have them prescribed to patients because they have less side effects, with the hypothesis, or maybe even the fact, which isn't a fact at all, that patients, in fact, discontinue medication because of side effects and intolerability. Well, this study shows that's not the case. Actually, patients discontinue medication because they think the drug doesn't work. And I find that a very, very important take-home message. You should really choose the drug that you give you first episode patients, that's what we're talking about here, on the basis of efficacy, not on the basis of tolerability of side effect profiles. That's what this study shows. And then there's panel D, that is like a leftover, and that doesn't really give you much information. So the conclusion is on this first study are the following. There are more conclusions, but these I'd like you to take home. So actually, medication continuation rates are possible in the first year. We're talking about a year after the first episode of 70%. That was the case with amisulpride and olanzapine, which is much higher than has usually been said. The reductions of symptoms in those patients who do well, I didn't show you these numbers, were considerable, about 60%. And GAF scores, which is the Global Assessment of Functioning, of 75, meaning moderately well functioning, were actually also quite achievable in the first year of illness. So what I'm saying you here is that actually, and I'm going to show that again in the second study, that patients do actually quite well in the first episode, depending though on the medication that you choose. And in this particular case, that was amisulpride and olanzapine. Now, the second bullet, discontinuation rates and motor side effects differentiates the SGAs, as I'm showing you, from haloperidol. Haloperidol in this low dose wasn't really very effective. And, like I said, only 30% was still taking the drug. But if the patient was still on the drug actually did quite well. So if a drug works for a patient, it works for a patient and the patient will stay on it. If it doesn't work, the patient will usually discontinue it. And again, the main message that I think you should take home is that discontinuation is driven by lack of efficacy, not, as is often said and often tried to convince you, because of side effects. It's just not the case. And many other studies have shown that as well since then. The second study that I promised I would present to you was then published in the American Journal. It's the same cohort of patients, but we now wanted to know, do these drugs work well on cognitive symptoms? And the sample is smaller than the entire sample because we didn't measure cognition in all of them. You can see them here, haloperidol in 50. It's about 15 each group, olanzapine a little bit more, but a smaller group, and this just shows you, by the way, the age of the patients, which is quite young, obviously, first episode, around 26, the number of years of education, was a fairly well-educated European group of patients. The PAN score, you can see about 90, which means they were quite a bit ill, and then their sex distribution, etc. Most were Caucasian, as you can see. But, the main result is the effect on cognition. And these are Z scores or Z scores at 6 months. If cognition was measured at baseline and at 6 months. And you can see that the effect, whether it's a composite score or some of the subtests, is really, the effect sizes are quite small. The composite is the biggest, but if you look at the individual test scores, the effect is really with effect size of 0.2 or 0.1 or 0.3. So these are not very large. And all the way in the right, you can see the p-value. You can see that these drugs, in fact, don't differ in their effect on cognition. So the effect of cognition is small to begin with, but there's really no difference between any of the drugs. And in fact, haloperidol is not doing worse. It's not doing better on the cognitive effects in these first episode patients. And interestingly, we also took a look at whether the change in cognition, which is on the x-axis, as you can see, the composite score difference, and on the y-axis is the relationship with symptoms. So you can see the positive symptoms, the negative symptoms, general symptoms, and the total score, which is all the way in the bottom right. But they're all, as you can see, they look very similar. And it shows that there is a highly significant correlation between the change in cognition and the change in symptoms. But, you know, it's obviously highly significant because we're talking about, 250 patients. So that this is significant is not really, very interesting. What is more interesting is that the correlation is actually very small. It's about 0.26, meaning it explains at best about 5% of the variance. And what that means is that although it seems in this correlation that change in symptoms is related to change in cognition, it really suggests that the two are totally independent. Because like I said, this relationship only explains 5% of the variance. So what this suggests is that these antipsychotics are really good at treating psychosis, as I just showed you in this earlier Lancet study. They're not so good at improving cognition, and the two are not really related. So you can improve on cognition and then really, improve on psychosis and not really have a big effect on cognition. So to conclude here, antipsychotics, at least the ones we currently have or that we tested, are not very effective in improving cognition in schizophrenia. And although the small improvement is correlated with improvement in psychosis, this explains less than 5% of the variance. In conclusion, antipsychotics are clearly not cognitive enhancers. And, in a different lecture, I could talk about the relevance of cognitive abnormalities in schizophrenia. In fact, suggesting that abnormalities in cognition are more relevant than abnormalities in psychosis in the course of illness and also in understanding schizophrenia. But the current drugs that we have really don't make a dent in that core aspect of the illness. Okay, I'd now like to move to the second treatment of first episode schizophrenia, the Optimize study. This is, again, a pan-European study funded by the European Union. And this had the question, okay, now what happens? What do we need to do if a patient in the first episode of psychosis does respond or does not respond? And especially the latter, of course. The patient doesn't respond. Should we switch antipsychotics or shouldn't we? And it may be surprising to you that, in 10 years ago or even less, this had not been studied. And as you well know, there is no algorithm for schizophrenia. There is no recommendation if a patient doesn't respond to their first drug, should we switch or not? Crazy as it may seem, there's no recommendation. Now, this is the study we published, like an outline of the study. And this was part of a very large grant, at least for European standards, about a 50 million US dollars, where we did lots of stuff. As you can see, we did baseline MRI scans, we did MRS scans. I'm not going to present those data. They've all been published. We've done the MRI studies, the MRS studies. We've done genetic studies. We've done other biomarker studies, immune-related abnormalities, and see whether they predict response. With some interesting results. Again, they have been published. Just, look at Optimize in PubMed. and you'll see them, but I'm not going to dwell on those. The main question was, as you can see in those gray, gray figures, we started out with about 500 patients, and then we treated them for 4 weeks with amisulpride. And why did we choose amisulpride? Because in UFEST we had found that it works very well. It's off-label, it's extremely cheap, and we thought we'd start with that one. And it's also a pretty selective dopamine antagonist, which is very interesting. Okay, so we gave it 4 weeks, and then we asked, have these patients remitted? We're not saying, did they have a response, like a 20% reduction in PANSS? And we said, have they remitted? According to the Andreasen criteria, which were published in the American Journal of Psychiatry many years ago, essentially saying that the patient only have mild or less psychotic symptoms. It's a pretty strict criteria. You do really well if you're remitted according to those criteria. Now, if they were not remitted, we said, okay, you go in phase 2, and then you go into a 6-week double-blind study. So this was double-blind, comparing either continuation of amisulpride or olanzapine. And then we wait for another 6 weeks. And if you haven't responded, haven't remitted, then we'll give you open clozapine. That's essentially the study. And clozapine we did for 12 weeks. This is a little map of Europe, and this in blue the countries that participated. And Israel was part of that too. Okay, so this is essentially a repeat of what I just said. The outcome again is all-cause discontinuation and remission. The primary outcome is remission according to the criteria that I just mentioned, and the secondary outcomes were all-cause discontinuation, symptom severity, social functioning, side effects, and physical examinations such as body weight. All right, so again, phase 1, open label, amisulpride. They didn't remit, 6 weeks double blind. If they didn't remit, 12-week open clozapine. The remitters went into a psychosocial intervention. That has also been published. I'm not going to go in detail. The long and short of it is, it didn't make a real big difference whether they had this intervention or not. If they're remitted, and they stay well with or without this psychosocial intervention. Okay, this study, like I said, was published in Lancet Psychiatry a few years ago. And this is, I hope you can read it here. But again, we started out with about 480 patients. The numbers were dropped out. It's a Venn diagram, not too much in detail, maybe interesting. But on the right-hand panel, the ones with the various colors, you can see we started out with 446 patients in phase 1, and then phase 2, I'll go through that in some more detail in a little while. We ended up with 93, so a much lower number. And in phase 3, which is the clozapine study, only in 28. You can see again, it's a young cohort, about 26 years, because, like I said, this was first episode, and I forgot to tell you that in this UFEST study and in this one, about 50% of the sample was actually medication naive. The sex distribution is about 30% women, 70% men. It should be 40-60 because that's the female-male distribution of schizophrenia in the general population. So it approaches that, but it's not good enough. Mostly, again, a European study, so most were white Caucasians, and then their living status. Most were schizophreniform disorder, as you will understand, or schizophrenia. But you can see, this again is testament to the fact they were early in the disease. And like in UFEST, we didn't exclude patients with suicidality. We didn't exclude patients with drug abuse because we wanted to be this as representative as possible. 60% of them, 62% were inpatients when we started. The rest were outpatients. The duration of untreated psychosis was about 6 months. So, not that long. And like 42% in this sample was actually medication naive, which is, quite a bit. And, a PANSS score of 80. So they were ill, but not very severely ill. Okay, so let me guide you through the numbers. So we started out with the open label study with 446, and after 4 weeks, we still had 371 in the study. So only dropout in 4 weeks of 17%. Now, again, this was an open study, but this is a very minimal dropout rate. But now, look at these numbers. We had 250 remitters and only 120 non-remitters. So after 4 weeks of treatment, now that's the other take-home message from this particular study, we had a remission rate of 56%. So I'm not talking about a response reduction in symptoms. I'm talking about only being left with minimal psychotic symptoms after only 4 weeks of treatment. So the message here is antipsychotics work. They really work, at least in a majority of patients. And they work quickly, within 4 weeks. So that was gratifying. And, again, in first episode patients, we're not talking chronic patients, but again, a very important, I think, take-home message is that at least amisulpride in our hands, it really works. A lot of patients achieve remission after only 4 weeks. So we ended up with 121 phase non-remitters, 93 accepted to go on in the double-blind phase. Here we had a larger dropout, 23%, which is one, it was a 6-week study, and two, it's a double-blind study. So unfortunately, we ended up only with 72. And then you can see that the remission rate isn't that high anymore. It was only 32 remitters and 40 non-remitters. So now actually the non-remitters are in the majority. So that's important. So if the drug doesn't work initially, it may not do so much better, but I'll get to that in a second. And then here we had a remission rate in the second 6 weeks of 34%. And then we ended up with 41 patients after phase 4. Only 28 wanted to go to clozapine. We ended up with only 18. So these numbers are very hard to interpret. A 36% dropout, only 5 remitters and 13 non-remitters, meaning that early in this phase, at least in our hands, in this, admittedly small number of subjects, clozapine helped a few patients, but, we don't know what continuation of treatment would have achieved because we didn't compare it with that. So that's a little bit disappointing. A remission rate of only 18%. Okay, but now the question is, does switching make sense? And the answer is, well, in fact, it doesn't make a big difference. So let's look at the panel A, B, and C. And that is the proportion in remission. Panel A is the first 4 weeks of amisulpride alone. And that is, over about 70%. And that is because it includes all the patients, excluding the dropouts. So that's, like I said, a very high remission rate. But now let's look at the second phase, panel B, where we compared the proportion in remission between amisulpride, which is blue, continuing amisulpride, and olanzapine, which is red. And you can see there's actually no difference. The proportion in remission after those additional 6 weeks is identical in both groups. So whether you continue amisulpride or whether you switch to olanzapine, it doesn't really make a difference. So that's take-home message number 2. At least in this particular study, switching didn't improve outcome. And panel C is, the very small number of clozapine patients. You can see the very wide confidence intervals. So I'm not going to go into much detail there. Another way to look at it is just to look at symptomatic improvement. Again, you can see the first 4 weeks in blue. You can see amisulpride. They started out with a PAN score total of about 80, and they dropped down quickly to about 50 something, or a little bit under 60. Don't forget that the minimal score of the PANS is 30. I mean, that's the lowest score you can get. So this was a pretty good improvement. But then you can see in the second part of the study, you can see the PANS score is higher. It started at about 75 because these were the patients who did not remit in the first 4 weeks. And then you can see in blue the change in symptoms on amisulpride, and in red on olanzapine, and you can see there is some improvement in both arms. It is, in fact, the result is identical after the additional 6 weeks, and it's actually not much to write home about. I mean, there's some reduction, but it's not that much. Again, emphasizing that if you respond early. And if you don't respond early, you have a problem. And then you can see the in green, which is clozapine. Of course, again, they start out at week 12 at a higher score because these patients had not been remitting in the first 10 weeks. And then you can see some improvement on clozapine. It's actually not inconsiderable, but again, wide confidence intervals and a much smaller number of subjects. So we need to take that with a bit of grain of salt. But again, the main message is if you respond quickly. Switching doesn't make a big difference or doesn't make a difference at all in improving outcome. And the effect actually after the initial 4 weeks is not that very large. So again, the conclusion in this particular study, the remission rates in first episode schizophrenia over 50% after only 4 weeks of treatment. Switching does not have a material impact in outcome after those 4 weeks. Continuation of treatments, I didn't give you that number, but if you add them all up, the 4 weeks and the 6 weeks, even though the effect of 6 weeks wasn't that large, there's still about 70%. And in this particular study, we can't make any predictions of whether using clozapine is very useful or not. It certainly doesn't harm. Okay, then the final study I want to review with you is the one that has not yet been published, but we recently submitted it, and that is the question of, are really long-acting injectables better in improving compliance or improving all-cause discontinuation? So this is the European long-acting antipsychotic schizophrenia trial, ULAST called, and this is what we did here. And very few studies have actually done that, surprisingly enough, is comparing the same molecule, either given as a long-acting injectable or as an oral. And the reason is that although it is usually said, well, long-acting injectables are much better in reducing all-cause discontinuation, these data are mostly based on registry databases. And not on trials. And if they're done in trials, they rarely head-to-head comparisons using the same molecule over a long period of time in a randomized design. So although there is certainly some indication that long-acting injectables may do better, we thought that it had not been sufficiently demonstrated, certainly not in comparative trials. So again, the map of Europe, the study, the countries that contributed to this particular study. And actually, yes, these are the studies. Okay, so again, the main outcome, all-cause discontinuation over an 18-month period, and is randomization of 4. I'll show you the arms in a second. Here they are. So what we compared is aripiprazole depot and paliperidone palmitate, which is the long-acting version of paliperidone, the oral aripiprazole and the oral paliperidone, and then the naturalistic follow-up that I'm not going to mention here in this study, the patients that did not provide consent to be randomized, but did provide consent to be followed. We thought would be an interesting comparison group because we would get a sense of, are these patients really who refuse to be randomized really different from the ones who are willing to be randomized? Again, it's a 17-month follow-up. They were randomized initially, and then the depot was given, and the switch was made if needed, and about 130 in each group. The primary outcome, all-cause discontinuation, and then again, due to lack of efficacy, safety issues, or other reasons, like we did in UFEST. So these were, by the way, more chronic patients. As you can see at item number 3, the first psychosis occurred at least 1 year and no more than 7 years ago. So UFEST was really defined as a group that had not been ill for more than 2 years and had not been exposed to antipsychotics for more than 6 weeks lifetime or more than 2 years prior to the randomization. So UFEST and Optimize were really first episode patients who had hardly been exposed to antipsychotics. And like I said, about 40 to 50% of them were medication naive. This is, for obvious reasons, a more chronic group of patients because, you don't, at least one may consider, but in this particular study, we didn't want to focus just on first episode schizophrenia. So a slightly more chronic group. Okay, so these were the inclusion criteria. This again, just to clarify. So here some more detail, but the main thing is how was all-cause discontinuation defined, not only as not showing up, but also if extra medication was given, which was especially relevant in the long-acting injectable arm. So sometimes a patient got a depot, but doctors thought, well, it's not holding this patient. It's not keeping the psychosis at bay. And then they increased it with oral rescue medication. That was possible just for a few days, but if it were longer than that, it was seen as a treatment failure and as an all-cause discontinuation. Same, of course, for the oral arm. So it was not just walking away, but also not showing up, but also if too much additional medication was needed. All right, so we ended up with about 523 patients. There you go. This is how they were assigned. A pretty good randomization, I think. About between 120 and 140 in each group. Here you have the oral combined and the depot combined. That was the primary analysis. Where the primary analysis would combine both orals and both depots, because that was giving us the most power. You can see that this is a slightly older group, which is not surprising because of the inclusion criteria. The women, about 30 to 35%, not bad, not as it should be, but not bad. Again, mostly white Caucasian. And then you can see, again, we did not exclude suicidal patients. We did not exclude patients with drug abuse or dependence for the reasons that I've now made clear, I think. They were not that really ill, the 75 of our pants, which is what you want to do. This is like essentially a continuation and not an acute exacerbation study. Okay, so this is again just to show you we have an intent to treat and a per protocol analysis, which is not that relevant. The primary endpoint. So look here at the numbers, which is, I think, important. So how many patients actually completed the 1.5 years, which is quite disappointing. Only 34% in the aripiprazole oral, very similar number in the depot, 36. Actually, paliperidone oral, as you'll see in the second, did actually pretty poorly. Only 24% completed the 1.5 years, and the depot was 36, so very much like the others. So this already gives you a hint, the oral drugs is kept made for paliperidone oral, and the long-acting really doesn't make a big difference. The number who complete are depressingly low if you compare to the first episode patients that are presented in Optimize and especially in UFEST. All-cause discontinuation numbers are very, very high. 1.5 years, 2/3 at least. And again, not much difference between oral and depot. If you look at aripiprazole, paliperidone is an outlier, the oral ones, but the depot is only 64%. So not a huge success, to put it mildly, for the depot. And here you can see them combined. The primary endpoint, all-cause discontinuation. This is not significantly different, although you've seen that in the curve, the number at risk you can see. But here, whether you have oral, which is in red, or depot, which is in blue, there's absolutely no difference in the proportion of treatment discontinuation. And you can see after 540 days when it was censored, we're talking about that at least 60% discontinued. Lack of efficacy, I mean, that was not a main reason for dropout, as you can see for both arms. But again, They're pretty identical. Do for safety, same thing. Not really a big reason for dropout. And interestingly, other reasons, and we'll have to look, is different. And therefore, the other reasons in dropout, there actually is a difference between oral and depot, where actually here depot does seem to do better. Now, for the other reasons, we'll have to look what that really means. Again, the overall primary analysis, there's no difference. These are post hoc analyses, but we'll have to look why for these other reasons there may have been a difference. And here, if you look at the forearms, the survival functions, you can see that the cumulative survival is very similar for the depot, oral, and Abilify. So Abilify oral and long-acting is the same. Paliperidone long-acting is all the same. They're almost identical, the survival, which is again under 40%. The really arm that did most poorly was paliperidone oral. We don't know exactly why that is, but that doesn't drive the difference between the two groups. So this is the per protocol analysis, just to show you whether we did a intent to treat or per protocol. It really doesn't make a big difference. It's exact same amount, no real difference between both. If you look at serious adverse events, fortunately, very few deaths, but unfortunately one in the depot arm of aripiprazole and the other in the paliperidone with a spelling mistake, but not related to the treatment, fortunately. Hospitalizations, actually pretty high numbers. And again, you can see there's no difference between the oral and depot. If anything, it's higher on the depot at aripiprazole. Now, this wasn't the primary outcome, but certainly not here the story that the long-acting injectables actually are superior in reducing rehospitalization rates. If anything, it's the opposite. But again, if you look at the forearms, it's not significantly different, but certainly no superiority for the long-acting injectables. So the final conclusions are that antipsychotics work. The final conclusion of all the 4 studies that I presented to you, antipsychotics work very well in reducing psychosis in first episode schizophrenia. And the main reason for discontinuation is lack of efficacy, not side effects. So again, if you choose a drug, choose it on its efficacy basis and not on the purported lack of side effects. Switching antipsychotics, at least in our hands and with the drugs that we studied, did not improve outcome of first episode schizophrenia. And again, in our hands, the superiority of long-acting injectables in schizophrenia in preventing relapse or hospitalizations or all-cause discontinuation was not borne out in the trial that I just presented. So with that, I think we can close, and I can probably stop sharing, which I'll do, and then people can ask questions. And I think they have done that. There are in the Q&A, and then there is in the chat. So what I'll do, I'll start with the Q&A, the 4 questions, and then I'll address those. So overall, are Europeans more compliant with their medicine than the US? Well, I don't know. That's a very good question. The question is, are Europeans more compliant than people in the US? I have absolutely no idea. I don't know, but it's an interesting question. Now, what I do want to address is, very often if you compare long-acting and orals, because I think that's what this question may be about, it's being said, well, you do with trials, so the patients are being seen more often, and that's where they'll be more compliant with the oral medication. Well, to avoid that, we actually didn't see these patients that often. We didn't give them extra care. And in Europe, certainly, insurance issues are not of major importance in guiding patients whether they show up or not, or whether they can pay their treatment. So we try to be as naturalistic as possible by not seeing these patients much more often than usual, by not giving them more care than usual. But you never know whether that may have made the difference. And the difference in the US and in Europe certainly is that in Europe everyone has insurance, which is adequate. So you may have a different selection of patients that are involved in trials. Another difference between the US and Europe is we don't pay there. We don't pay the patients in trials. Actually, we're not allowed to do that. So that may be another difference in selecting patients. We have patients who usually are part of the trial because they want to do good and they want to help science, not necessarily to get free treatment because that's not necessary, and certainly not because they think they can get paid because they won't get paid. So maybe that is a difference. These are all quite possible. Why there may be differences between findings in the US and Europe. Very good point. Okay, here, I do not believe schizophrenia always has a chronic course. Some people only have one episode in their lifetime. What are your thoughts about that? Well, that is a very interesting question. That depends how you define schizophrenia. I would define schizophrenia itself as a chronic illness, mainly defined by cognitive symptoms that precede the onset of psychosis by 10 years, by a decade, and then by a more chronic course with negative symptoms and psychosis. But you're right, there are patients who only have a single episode and sometimes respond very well to medication. And that can happen. I agree with you. And that is probably still schizophrenia. And then the dilemma is, what do you do with these patients? I mean, if this patient has been, had a severe episode, you've treated them, and he or she belongs to the, the fortunate 60% that has remitted after 4 weeks. Do you keep that patient on the medication forever, or do you discontinue? That's a very, very, very tough clinical question. And as clinicians, we all know, we know these patients, that they have done well, and we did discontinue the medication after 2 or 3 or whatever years, and then they relapse. And then it's very hard to get them back on track after that single relapse. So it's a very, very difficult question. It may be very unfair to treat someone lifetime for a single episode. And it's very, very justified to discontinue medication at that point. On the other hand, I think, we all as clinicians have our cases that we know that we have discontinued the medication, the patient relapsed, and we feel very bad that we discontinued the medication because we can't get them back on track. So yes, I do believe it can have a single episode and the patients can do well. Yes. So Nicola, do you believe it's ever necessary to treat patients with 2 different antipsychotics? Very, very good question. There are very few studies that have actually looked at that. Again, if you look at, population-based studies and registry studies, there is some suggestion that 2 medications may do better than 1. I would love to do a trial like that. It's not easy to design a trial like that because which medication do you use, and if you have been done, the jury is still out. You obviously have to do a placebo control because it may be just the idea of adding a second drug that may make the difference. But is there a guideline saying add another drug because it's helpful? No, there isn't, just as there isn't a guideline that switching does or does not make sense. Would I like to do a trial like that? Yes, I would love to do a trial. I think it's a very, very interesting question. A lot of physicians will, use combination treatments, but the evidence is still out. Clozapine may improve psychotic symptoms, but not quality of life. Well, of course, that may be true, but I respectfully disagree in the sense that I've, actually sometimes seen the opposite. That I see patients who do extremely well in quality of life on clozapine, but still have some psychotic symptoms. So it depends on the side effects. As we well know, clozapine has a huge number of side effects, which may sometimes be very debilitating, and some patients will not tolerate that. On the other hand, we all have seen the Lazarus effect in patients with schizophrenia that have done extremely well and almost been cured by clozapine. So I think we should try it on all the patients that have been refractory or have unsatisfactory responses to antipsychotics, I think we owe them clozapine and then see how they do. What is the evidence that drugs were selected based on, what is the evidence that drugs were selected based on efficacy instead of side effect? Does this mean that patients had to deal with side effects if they were efficient in treating psychosis? Well, the evidence is that, as I showed you in the UFEST trials, that very few patients dropped out, even on haloperidol, that dropped out on the, and then indicated, well, I drop out on the basis of side effects. I don't want this drug anymore because it has too many side effects. Whereas on the other hand, the patients that did drop out, many of them said, I don't want this drug anymore because it doesn't work for me. So that is what I'm basing this evidence on. And it's the same that we found in the optimized studies, that the patients actually indicated that they stopped the medication not because of side effects or intolerable side effects, but because they thought the drug didn't work. Same for the doctors. They often stopped prescribing the medication because they thought that the drug didn't work, not because of side effects. How can you treat clozapine discontinuation symptoms? Yeah, I mean, that's not something I addressed here, but there are various clozapine discontinuation symptoms. Don't forget that clozapine is a highly anticholinergic drug. So sometimes you get cholinergic rebound. And these side effects obviously can be treated best with anticholinergics initially. I mean, they will pass on, they will, move on and decrease over time. But if you want to treat the cholinergic rebound, you could use anticholinergic. And you have some maybe dopaminergic rebound, and you can treat them with a low dose of an antipsychotic, for instance, like quetiapine. An important blog about severe clozapine discontinuation symptoms was actually provided here. Okay, great. Thank you so much. Those were the Q&A, and then there's in the chat box. Oh, that was for me. Please put any questions in the Q&A. Okay, fine. That was it. Okay, I think I addressed all the questions that were in the Q&A box. There is this blog, which is actually clozapine discontinuation.blogspot.com, if people can see that. All right. Okay, then, well, thank you so very much for your attention and your questions. If anything comes up later on, you know where to reach me. You can send me an email, and I can address the question later on digitally. And then we'll close with that. And thanks again for your attention and your participation. All the very best.